Welcome, everybody. Thank you so much for joining us today for our presentation, the U.S. COVID-19 County Policy Database, a novel resource to support pandemic-related research with Dr. Rita Hamad. Today's presentation is brought to you by the Social, Behavioral, and Economic COVID Coordinating Center, or SBECCC, at ICPSR. And for any of you who are not familiar with us, we are a center for communication and collaboration among NIH-funded projects, undertaking social, behavioral, and economic research on COVID-19. We promote an innovative cross-disciplinary approach to COVID-19 research across the behavioral and social science community, multiple NIH award recipients, and the public. If you haven't already, we hope you'll take a moment to visit our website, where you can join our mailing list to receive our semi-annual brand new newsletter and other occasional updates. Now I'll turn it over to Dr. John Kubali, Project Director for SBECCC, to introduce today's speaker.
Thanks, Megan. So we are thrilled to welcome Dr. Rita Hamad, a social epidemiologist and family physician in the Philip R. Lee Institute for Health Policy Studies and the Department of Family and Community Medicine at the University of California, San Francisco. She's the director of the Social Policies for Health Equity Research Program. Her research focuses on pathways linking social factors like poverty and education with racial and socioeconomic disparities in health across the life course. In particular, she studies the health effects of social and economic policies using interdisciplinary quasi-experimental methods to generate actionable evidence to inform policymaking. Dr. Hamad is the Associate Director of the UCSF Center for Health Equity. She is also a member of the steering committee of the UCSF Population Health Data Initiative, serving as the faculty lead for the development of data infrastructure to advance population health research on campus. Outside of UCSF, she is the co-chair of the Communications Committee of the Interdisciplinary Association of Population Health Sciences and was a fellow at the National Academy of Medicine from 2020 to 2022. And with that, Rita, I'll turn it over to you.
Great. Thank you, Megan and John, for the introductions. And let me just get my slides going here. Hopefully you're seeing the right screen now. Not the notes view? All right, great. So glad to see everybody here today. As John and Megan mentioned, I'm going to be talking today about a new policy database that our team has been working on with the support of our NIH UO1 grant. It's called the U.S. COVID-19 County Policy Database, or the UCCP. And let me jump right in. So here's an overview of the topics I'm going to be covering today. I'm first going to describe the importance of policies as determinants of health more generally and specifically during the pandemic. I'm then going to briefly describe two of the existing policy databases out there, which focused on national and state policies. I'm then going to talk specifically about the UCCP database that we are creating on county level pandemic policies, including some preliminary results that we can share already. And finally, I'm going to talk through our planned next steps before taking questions. So first, I'm a social epidemiologist. So of course, I'm going to start with a little bit of theory about why we're interested in studying policies as determinants of health. Some of you might recognize these concentric circles as representing the social ecological model. It depicts the factors that contribute to health as a nested set of determinants, with individual risk factors as the most proximal or downstream, and then increasingly upstream factors representing more structural determinants, those that are embedded in institutions and governments. And in this case, we're going to be talking about social and economic policies as the most distal of these determinants that have the potential to impact health and inequities at the population level. So again, as an epidemiologist, we love our causal or conceptual diagrams. So this one illustrates the link between policies, the orange box, and health outcomes, the turquoise box. For this particular project, our focus is on pandemic-era county policies, including containment and closure policies, economic support policies, and public health policies. And our outcomes for this particular grant include mental health and health behaviors. So we hypothesize that these policies may support or adversely affect employment or income, as well as perceived or actual risk of infection. These may then impact the outcomes directly or through the pathway of healthcare utilization. So we do have potential confounders that may affect both the exposure and the outcomes, including local COVID-19 rates, as well as other county level factors like social and economic characteristics or urbanicity. And finally, we have potential moderators, that's the green circle, and these might result in different effects for different subgroups, things like race, ethnicity, or education. So to be able to answer research questions about the health effects of these policies, we need to have an adequate characterization of these policies. This will allow us to understand the variation in the policies during the time period, as well as to understand how policies bundle together or are sort of implemented at the same time. So before our study came on the scene, the two main existing policy databases that address subnational policies were the Oxford Coronavirus Government Response Tracker, or OxCGRT, and the COVID-19 US State Policy Database. So the Oxford database includes both national and state policies, and they really focus, they have an international scope. In the US, they did track state policies, and they grouped them in 3 domains, again, containment and closure, economic support, and public health. And they're sort of a little bit more heavily focused on policies targeted towards infection control. For example, the database includes really detailed indicators of vaccine policy and then how different containment and closure policies differed based on vaccination status. Meanwhile, the CUSP database includes primarily state-level policies in the US, as the name suggests, and this database has additional focus on disparities. So, for example, includes information on whether state COVID-19 data are disaggregated by racial and ethnic subgroups. So neither of these databases focuses on county-level policies, where we know there was a lot of variation in the US. And a few studies have looked at county policies, but often are sort of really narrow in the geographic scope, or they looked at just one single policy indicator over a wider geographic range. And no databases or studies, to our knowledge, really focus on systematically characterizing county policies nationwide. So that gap is what motivated our current study. And our objectives are to document US county level COVID-19 policies during the pandemic to achieve a few broader goals. So first of all, we hope to be able to better characterize geographic and temporal variation in these policies. Second, we want to be able to examine the effects of these policies on mental health and health behaviors, and to support the use of this database to examine other health and social outcomes. And third, we want to adequately account for confounding. So in other words, we want to reduce the chances that we attribute effects to just one policy, like workplace closures, when other co-occurring policies like eviction moratoria may have been occurring at the same time and may have actually contributed to or reduced the effects of the main policy of interest. So here I am today introducing you to this database that will soon be available, and it's the US COVID-19 County Policy Database, or UCCP. So in terms of data collection, we're gathering data on 27 different policies for over 300 counties across all 50 states and Washington, D.C. So there's over 3,000 counties in the US, and the 300 that we have here include more than half the US population, and they're pretty diverse with respect to geography, race, ethnicity, and politics. It is a randomly selected sample of counties where we sampled proportional to county population and oversampled counties higher on the CDC's Social Vulnerability Index, while at the same time trying to ensure adequate representation from non-metro and rural areas, and getting at least one county per state. So this is not strictly a nationally representative sample, but our goal here was to ensure broad coverage across the country. The time period that we cover is 2020 to 2021. And during that period, we're collecting data on these policies at weekly intervals. And I get a lot of questions from people about how big our team is to accomplish this task. So we have 4 full-time data collectors and a project manager who does some part-time data collection also. So it's a fairly large team, and we anticipate that the full period of data collection is going to take about 18 months. So in terms of the policies included in the database, as I mentioned, they're grouped into 3 domains, which are modeled slightly on the Oxford database, although we did have to change them slightly because policies are sort of have a slightly different focus and are structured differently at the county level, and some of the national and state policies that they were collecting, like immigration controls, weren't relevant for counties. And we also added additional policies in the economic response domain because of our focus on health equity. So you can see the listing of those policies here. And our data collectors have several sources that they consult when they're looking for information on these policies online. And this is a list of the primary data sources that we instruct them to consult in roughly the order of priority. So at the very top of the list is websites of health departments, county health departments. For school policies, of course, they consult school district websites, and for public transportation policies, they consult the websites of the relevant local transportation agency. They then prioritize other government websites. And then after that, if they still don't find information on the policies of interest, they consult news articles and then social media. And then to be specific, this is not like the social media of your local celebrity or influencer, but it's the social media accounts of the government agencies or of the news organizations. And then finally, they might also consult like secondary data sources, like other policy databases that may have captured the policy in real time. And then in terms of how often we use each of these sources, so about 90% of the data that we've collected so far come from either a health department website or some other type of government website. Although for economic support policies, we often have more success looking at the social media pages of the government agencies where these economic support policies are announced. So this brings me to the next unique feature of our methods. So obviously we're gathering this data retrospectively now, since we weren't funded to do this project until sort of the end of 2021 when the pandemic was more than a year in. And one resource that we're relying on to make up for this is the Wayback Machine. So for those who haven't heard of it, this is an initiative of the Internet Archive. Internet Archive is a nonprofit. It provides, as the name suggests, an archive of websites across the internet. It's sort of continuously crawling the internet to find websites and then archiving them periodically across time. And so here's an example from the Wayback Machine for the COVID-19 information page of Burnett County, Texas, from March 30th of 2020. And you can see that it provides information on the shelter-in-place order at that particular time. So the Wayback Machine is allowing us to gather policy data retrospectively, and it has been a tremendous resource for our team. So far, we've probably used it like for 40 or 50% of data collection points. So I also want to show a couple of examples of the type of data that the data collectors abstract from these websites and how they do that. So here's an example from the data collector's manual for one policy, which is restaurant closings. So the coding, you can see on the left, the coding for the policy has several categories ranging from 0, no restrictions in place, to totally closed. And then for each policy, we also have an interpretation guide, which is shown on the right. And this helps data collectors deal with potentially nuanced situations. And this part is continuously updated so that the nuances are consistently coded if the same issues come up repeatedly. Here's an example of another policy, utility support. This one just has 2 categories, any support versus no support. And in this case, also we have the interpretation guide there on the right to continually sort of capture potentially nuanced situations that might come up. So because of these potentially nuanced scenarios, we want to be able to ensure high data quality and that we have adequate inter-rater reliability. So to do so, we did a round of double data collection in 2022. And in this case, we had, we randomly picked 10 counties, and we had another data collector go back and collect again the data for that county. This included the county's entire time period of 2020 to 2021, those weekly intervals for all 27 policies. And that gave us about 2,000 data points per county that were double data entered. So we then calculated inter-rater reliability 2 different ways. First, we did just the simple percent agreement and found that about 80% of each of those data points was exactly entered the same way across both data collectors. We did see some variation for individual policies, as low as 62% for school closings and then 98% for vaccination availability, although most were right around 80%. And of course, this percent agreement was a little bit higher when we considered situations where the 2 data collectors coded policies at almost the same level of restrictiveness, but maybe were like 1 category off. So we also calculated a kappa statistic, which is a little bit more sophisticated measure of inter-rater reliability. And for this one, this indicated that there was moderate to strong agreement across data collectors for most policies. And I'm not going to get into the nitty-gritty details here, but the statistic is not exactly right for our situation since we had non-overlapping sets of staff coding each county. And there were also a fair number of policies that had really rare prevalence in certain categories, and kappa statistics just don't perform well in those situations. But overall, we were sort of reassured about our data collection process. And other than this double data entry, we also have the program manager sort of going through and doing spot checks with data collectors and looking at the data that have been entered to make sure that they're being done consistently. And the data collection team meets on a weekly basis to discuss anything that might be coming up. So before getting into the preliminary results, I did want to talk about another handful of challenges that we've encountered. So we have been finding that smaller and non-metro and especially rural counties are less likely to have policies documented at all. And in these cases, we assume the county was simply relying on the state policy at that time, and we fill in the policy with that of the state. And more generally, in cases where we find no documentation at all for a given policy, we assume that there was no policy restriction in place. We figure if we're doing this like extensive online search proactively and not finding any evidence of a restriction, we assume that the same would be true of the county's residents, so that functionally no policy was in place. A more challenging situation that we're encountering, not that often, but occasionally, is when we see evidence of a policy being implemented, but then no documentation of it ever being stopped. So for example, in some cases, we see counties announcing a policy that they're canceling public events, but then never see in the official records that the restriction has been lifted. And in these cases, we just try our best to do a best guess. For example, if we see that the county is then hosting in-person events again on its calendar, we figure that the restriction has been lifted at that point. So finally, on to some preliminary results. So this first manuscript we published was sort of a practice run for the larger county policy data collection. Here we were testing out our procedures with the Wayback Machine, et cetera, and documenting policies that took place federally and within California, with a special focus on safety net policies and other policies that might affect disadvantaged groups. So this timeline included March of 2020 to November of 2021. And the domains don't exactly line up with those that we're including in our current data collection, but even without getting into the county policies, this figure illustrates the sheer number of policies happening federally and at the state level. And one major gap that this initial preliminary data collection helped identify was that there was very little policymaking to support childcare infrastructure, which was already lacking in the US. And this, for example, might help explain the substantial decline in women's employment over the first few years of the pandemic. So for the next few slides, I'm going to focus on another trial run we did of our data collection. This was in January to March of 2021, just a cross-sectional time point. And here we were gathering data on 100 counties in 7 states for 22 different policies. This study has already been published in BMC Public Health, the citation's just below. And here you can see the variation in stringency or comprehensiveness for each of the different policies across counties. This table in particular is showing the containment and closure policies. The gray areas mean that the scale just didn't go up that high. So in other words, for schools, the scale went from 0 to 3, and for public events, it went from 0 to 4, et cetera. So again, in that first row, we see that at this point in the pandemic, 76% of counties had less restrictions for school districts. And meanwhile, 71% of counties had restrictions on private gatherings. For most policies, there was very low missingness if you look at that first column. Although for nursing home policies and curfew requirements at the bottom, about a quarter of counties just didn't document that type of policy at all. This next table shows the variation in economic response and public health policies in these 100 counties at this point in the pandemic. Here we see that 3/4 of counties had some kind of housing support and almost 2/3 had utility support. And for the most part, public health policies like testing, contact tracing, mask requirements were fairly comprehensive. So the next thing we examined was how correlated these policies were with one another, sort of like how bundled the implementation of these policies was. And this plot shows bivariate Spearman's correlations for each pair of policies. Dark green means that the policies are highly positively correlated with each other, and dark red would be highly negatively correlated. And we see a lot of correlation in implementation of containment and closure policies. You see a big cluster of dark green up at the top, and those are things like workplace closings, restaurant closings, restrictions on private gatherings, and those all have correlations of about 0.8. There was less correlation between other types of policies, with a lot of the correlations between 0.2 and negative 0.2, sort of the yellow colors, meaning they're very weakly correlated, and not a ton of negatively correlated, or not really any negatively correlated policies. So for this figure, we added up the number of policies in each county. As I mentioned, for this round of data collection, it was 22 policies, so the score goes from 0 to 22. Darker green means more policies were implemented, and counties in white here were those that weren't included in this round of data collection. So here you can see variation both within and across states. For example, the California counties on average have more darker green boxes or more policies than Louisiana counties, for example, but you can see plenty of light green and dark green counties across both states. Finally, this last preliminary result is the first one we have to share from our longitudinal data collection. So you guys are getting the first glimpse of this. And this is a spaghetti plot, and it shows comprehensiveness in the containment and closure policies across counties in 5 different states for a roughly 15-month period. So while you can see the same general patterns with increases in policy implementation during various early surges in the pandemic, the levels of comprehensiveness are definitely different across states. And this is the same or similar plot, but for economic policy comprehensiveness. And at this point in the pandemic, economic supports were generally continually getting more generous, with the exception of sort of a brief dip in early 21 for Florida. So in terms of our team's next steps, of course, we're continuing data collection and quality checks. We currently have about 166 of the 310 counties finished, so a bit more than half. We're next going to plan to do a systematic characterization of geographic and temporal variation in these policies during this period. We're then going to link the policy data with national survey and administrative data to evaluate the effects on mental health. And then finally, we're working with a policymaker advisory board throughout. They helped us design the data collection early on, and then hopefully they will be helping to inform the analyses and the dissemination. Of course, there's no way that we can fully take advantage of this data set ourselves, so we do plan to make it freely available to the research community and beyond. The first round of data collection that I just shared a bit about, the 100 counties in 7 states just for January to March of 2021, is already available. You can go to that website there, take a screenshot, or you can scan the QR code. That'll get you to the paper and the data repository, and those are being hosted at Open ICPSR by our colleagues at the University of Michigan. We anticipate that the full 2 years of data across all 50 states will be ready by the end of 2023. And it's important to note that these counties don't fully overlap with the 100 included in the preliminary data collection. So if you're really interested in looking at that longitudinal component, you have to wait a little bit longer to get your hands on that. So before I end, I want to acknowledge our amazing research team. This work is a huge undertaking, and I want to acknowledge first and foremost our data collectors who are working all day, every day to create this tremendous resource. And I got this great picture of them in front of the Golden Gate Bridge here in San Francisco during our recent team meeting. And I also want to acknowledge the other co-PIs and collaborators on this work based at the Louisiana Public Health Institute and UCSF. I want to acknowledge our consultants and, of course, our funders at PCORI and NIH. If you want any more details on the study procedures or the list of counties that are going to be included in the longitudinal data collection or anything else, please do check out our team's website. And thank you again for your attention, and I look forward to your questions. Let me stop sharing so I can see you guys. There we go.
Great. Thank you so much, Rita. We appreciate that. We can now throw it open to questions. If you have any questions, please feel free to type your questions into the chat. You can raise your hand. If you prefer, you should be able to unmute yourself and ask your question directly as well. And I can get started with a question for you, Rita. We had a question from someone: how can we partner with county and state departments of public health to help evaluate the impact of their local level policies?
Yeah, that's a great question. I can speak a little bit to what we have done for this project so far. We've tried to engage with policymakers at different levels throughout, even from when we were writing the initial grant. We want to ask research questions that are relevant for researchers and, the theory of how policies impact health, but also we want to know what policymakers want to know and what sorts of evaluations would be helpful to them. So we reached out early on to, our team is based both at UCSF and the Louisiana Public Health Institute. So our local policymakers, we sort of worked our networks as best we could to also get connected with state and federal national policymakers. And this isn't just sort of elected officials, it's all kinds of people who make policy. So for example, through the California Department of Public Health, the National Association of State Mental Health Program Directors, I think I got the name of that organization right. And just, I had meetings with them, hosted roundtables. I mentioned that they were helpful with the study design. We sort of shared with them our list of proposed policies, and they, one of them pointed out, you don't have nutrition policies on there. And that was like really important to figure out early in the process. And we're sort of hoping to continue to meet with them through small group sessions to continue to get their input on how can we analyze this differently to make it relevant for them and to impact decision making.
Yeah, thank you. I see 2 raised hands, but the first I'm going to turn to the question that showed up first in the chat, which was Catherine asks, are the 100 counties available now a subset of the 310?
So yeah, so that's what I was hinting at towards the end of the presentation. It is not, they're not exactly a subset. Some of them will be included or are being included in the full 2-year longitudinal data collection, but not all of them. And if you go to our website, the sphere.ucsf.edu, and navigate to the COVID, the part where the UCCP database is described, we have a list there of all the counties, so you can sort of map onto there and figure out which ones are included. And maybe we might be able to do a better job of indicating which are the ones that are already in that preliminary release, but it's not all 100 will be.
Thank you. John, would you like to ask your question?
I just had a quick clarifying question. I think you mentioned this, but when you were talking about the comprehensiveness, in those spaghetti plots, is that, kind of, simply a sum score of, the number of policies, or if not, how is that calculated?
Yeah, so that plot in particular that I showed is just a sum score, like any policy versus no policy. In that initial publication that we did in BMC Public Health, we did calculate it a different way. So for example, if a policy had like 5 different categories going from 0 to 5, we set 0 to be 0, and we set the most restrictive to be 1, and then we sort of gave it gradations in between and then added them up that way so that it's sort of weighted by how comprehensive or strict a given policy was. And the results are sort of generally the same. The scores are obviously just like a little bit lower because they're weighted. But that particular plot was just adding up yes, no, any policies.
Gotcha. Thanks for clarifying.
Mm-hmm.
Thank you. Doug, would you like to go next?
Yes, thanks. This is, I can appreciate just how much work this is. And a topic that's of particular interest to me is within state variation, like county to county variation in your various policy dimensions. Of course, you're going to be limited in how complete a picture of that we can ever get because of your sampling basically 1/10 of the counties. Nevertheless, I wondered if I got kind of a multi-part question. Have you looked at and tried to quantify within state variability? I mean, you got lots of Utah and lots of California, I noticed. And can you say much about the extent to which within state variation exists because of an absence of state level direction, and how much it doesn't exist because of state level direction? If a state health department says you've got to do this, then in principle, at least, all the counties in that state should do that same thing. But in the absence of that kind of strong direction from the state, that seems to leave open the possibility for a lot of within state variability.
Okay, yes, that was definitely a multi-part question. Let me try to remember all the parts, and you might have to remind me also. So in that first round of data collection, we had a lot from California and a lot from Utah for reasons I won't get into right now. So I'll just speak to that preliminary research that we've done. So we definitely saw a variation within states. The way that we sort of crudely measured that for that study is we looked at sort of like the mean and standard deviation of the policy score within states, and you could see that the standard deviation did vary a lot, so that there was like a greater range in some states versus others. And then the other thing that we noticed, again, just for those initial 100 counties in those 7 states at that one point in the pandemic, was that there were definitely states in which there was not a lot of county policy making going on, and we had to fill in a lot from what the state was doing. And so that did result in less variation in those states, just because the counties weren't particularly active, and so they were all sort of coded similarly. So that is definitely the case, and we're obviously hoping to explore that more when we have more of the longitudinal data, a bigger variation of states, et cetera. I feel like I'm missing part of your question. Is there part of it I didn't get to? It's okay.
No, that's good.
Okay.
In the chat, Renzo asks, are you collecting any measure of policy compliance?
Yeah, we are not doing that. We're just looking at, was the policy actually implemented by the county? I know that other people have done that for different studies, depending on what the indicator is, like, trying to capture shelter in place compliance by looking at cell phone data, that sort of thing. We aren't doing that. We're just like literally looking at like, what did the government say you should or should not be doing? Or what kind of support was it offering or not offering?
Thank you. In the chat, John asks, is there policy contagion in that when one locale initiates a policy, nearby locales follow?
That is a great research question that you should be able to answer with our data when they're ready, because we're getting at really granular weekly intervals, and many of the counties in our study are sort of geographically proximal to each other. Hopefully that's the sort of thing people can answer. That's not one of our research questions, but they will be there for you to download and look at.
Elise, you want to unmute and ask your question?
Okay, great. This is really interesting. So thank you, Rita. My question was, so you're looking each week whether the policy is there or not. So I'm thinking with policies, they get enacted and there's an enactment date and the effective date. So are you just saying it's in place, it's effective, not when it was enacted, if it doesn't go into effect right away?
Yeah, so it would be the effective date, right?
Okay.
Mm-hmm.
Thank you.
Yeah.
Yeah, John, please go ahead.
Sorry, just one more question after your answer to Doug. I was just curious if you saw, I'd imagine that, the type of health department structure that a state has, whether it's centralized or decentralized, would influence, the level of, kind of county level variability. Is that something that you saw or were able to look at, or?
I don't, we definitely didn't look at that. In that first study, because it was just 7 states, we might not have had enough of a sample to really say that's what it was. But again, that's something that could totally be looked at. And one of the questions that like a reviewer of that paper asked us that we also haven't dove into yet is like some states have really strong preemption laws, like they don't allow local governments to make policies in certain domains. So I think totally, like I'm not a political scientist, I'm a social epidemiologist, but I hope political scientists answer those questions because I'm really interested in hearing the answers too.
We had another question from a registrant a little while back. Are you aware of the data on state alcohol-related policies adopted in response to the COVID-19 pandemic, published by the Alcohol Policy Information System?
So I saw that question and I did not incorporate it into the presentation. I was not aware of that before this. We weren't quite as focused on policies just on those types of health behaviors, but I don't know if you want to drop the name of that database into the chat in case there are people specifically interested in alcohol policies, like they could look up that as well. Yeah, so I wasn't aware of it, but I think this is more of an educational question, right? So for people who are more interested in the alcohol policy specifically, there is that database.
Okay, are there any other questions? I don't see any in the chat. Please feel free to raise a hand, unmute, or drop something in the chat if you'd like to. Okay, if there aren't any other questions, then we'll wrap up. Thank you all so much for attending today's webinar. We'll send you a copy of the recording and slides within the next couple of weeks. And we hope you'll join us for a future webinar. Thank you so much, everybody. Have a great day.
Thank you.